Hi, I'm the director for our New Zealand registered charitable trust called Common Knowledge. And in the early 1970s, I had the privilege in the United States with working with hundreds and fathers of mothers who developed what is now called the Birthing Better skills. And our trust holds all those skills. So we are a registered not for profit and we're an educational trust. And for 50 years, families had asked me to carry forward a concept. And that was a concept that we hoped would become a childbirth trend, which was in pregnancy, it's normal and natural to self learn birth and birth coaching skills, and then use those skills to work through the activity of birthing your baby, no matter the circumstances. We get pregnant to have babies, we don't get pregnant to have a type of birth. And it's always an activity that each woman is doing with her baby and hopefully has a supportive partner or other who can help her. And what's the help that they're giving? Well, it's a big event. It's like an Olympic event or climbing Mount Everest. So it's big. It has internal sensations and it has things that happen to or around you. So the job of the person who's helping you is to help you cope and to manage and to feel in control and to stay on top of both the internal sensations and what's happening to or around you. So when I gave birth in 1970 and started to work with these families shortly afterwards, the word intervention was not used in childbirth. We were sort of the second generation. I was born right after the Second World War in the United States, and that generation was really the first generation in which pretty much everybody started going to the hospital for birth, at least in the United States. There were some areas where that wasn't accurate, but by far the vast majority of modern post-World War II women believed that modern maternity care would, one, is to reduce the suffering from the natural occurring pain of contractions, and also prevent any risks from becoming problems and problems from becoming tragedies. So when my generation, the second generation of women to birth in hospital, we went in and we had assessments done and monitoring done and procedures done. By the way, other countries around the world that had an integrated midwifery system, home birth was still very much part of the maternity care. And even with maternity care at home, every midwife is obligated by a professional practice to do assessments, monitoring, and perhaps procedures. And the difference between midwives, whether they are nurse midwives or whether they are direct entry trained, is that they have a certain level of skill, and doctors and obstetricians have other levels of skill. That doesn't reduce the effectiveness or the professionalism of people with different skills. It's just that there are different skills within any field. Doesn't make obstetricians better than midwives. It doesn't make midwives better than obstetricians. It just means that they have a different set of skills for the focus that they have. So when I gave birth in 1970, the word intervention was not used. However, when I gave birth last in 1982, 12 years later, it was being used. And so something happened between one trend and the other. And by the way, when I gave birth in 1970, the first childbirth preparation classes ever were being taught, and they were entirely skills-based. So that meant that I was sort of in the middle of the generation from the 60s to the mid-70s, where because Lamaze and Bradley were taught everywhere in the United States in every hospital, and they were offered as classes by private people as well, is that multiple millions of families like mine use skills to birth their baby. And that was phenomenal because nobody in the history of mankind had really thought that we could use skills to cope better and not suffer. And they were extremely effective for that, extremely effective when they worked well. And sometimes they didn't work well, they didn't adjust well. It was the beginning of a concept of skills, so we don't expect them to be as sophisticated as they can be when they evolve and mature. But they were good enough to prevent suffering by millions upon millions of women, and to have millions upon millions of fathers come in and actually know how to help us. And that was remarkable. The sad part of all of that good news was that Lamaze and Bradley, and the beginning part of the natural birth movement, saw those skills as targeting low-risk women rather than all pregnant women who would birth, and that those low-risk women then could achieve the three narrow goals put forth by Lamaze and Bradley in the beginning part of the natural birth movement, which was to achieve a natural birth, pain-free labor, with no medical care. And not enough women achieved that. And there were lots of reasons why they didn't achieve that. And part of the reason had to do with the fact that modern medicine developed assessments, monitoring procedures that became standards of practice, or the guidelines to practice, or the evidence-based practice of the day. And why were those assessments, monitoring, and procedures done or adopted? Because they're there to try to assess if there are risks, monitor risks so they don't become problems, and have procedures available in case a problem looks like it could become a tragedy. So we just accepted them, didn't always like them. When I went in and gave birth in 1970, we couldn't eat or we couldn't drink. We couldn't, because if we had to be knocked out with a general anesthetic for a cesarean, which was only a 4.5% cesarean rate then, but it was done under a general anesthetic. So if we ate or drank, we could vomit, and then we could aspirate that into our lungs. So we couldn't eat or drink. We couldn't get out of bed because there was a perception that moving around would break that sterility that was so important. And why was sterility important? Because germ therapy had just been understood a half century earlier. And prior to that, women died of milk fever or sepsis after birth. And so one of the benefits that modern people saw about modern medicine was that they would reduce the risks of this situations such as postpartum sepsis or blood poisoning, which caused women to die. There are many risks around pregnancy and childbirth. Life is full of risks, as we say. And you're more likely to die of absolutely anything in life except giving birth or being born. However, we place a lot of value on childbirth now because we now have birth control, and we now have, in some countries, the right to terminate a pregnancy. And so women are having fewer children, which means we place more emphasis on the importance of that child not being put at risk. So my generation of women gladly accepted the monitoring and the assessments and the procedures because those were things that were beginning to address the common risks and the uncommon risks that have always been associated with childbirth. So when I gave birth in 1970, there was a 4.5% cesarean rate done to save women's lives. And every other risk was really considered to be normal and natural and physiological. And people took the risks. They considered it to be normal. And the pressure by the consumer onto the modern medical system really started towards the beginning of the 1980s. Women that were Rh negative, there was nothing that could be done. And babies were definitely put at risk if they had an incompatible blood type. And so consumers put pressure onto the medical community, and eventually ROGAM injections were given to women to prevent that antibody reaction. That didn't exist when I gave birth in 1970. So when we're looking at the word intervention, we need to know that that word didn't exist in 1970, but it began to be used in 1982. And what was interesting, because I became involved in this conversation in the early 70s, was how it became used. And that had to do with the rise of the global natural birth movement. Now, sometimes when I talk about the natural birth movement, it does sound to people listening to me that I'm knocking it. And in a lot of ways I am, because the messages that we as women have given each other through that movement has caused a lot of the shame, blame, guilt, disappointment, anger, frustration, and emotional birth trauma so many women of your generation experience today. And on the other hand, no, I don't knock the natural birth movement, because it's really, really important that we keep in mind that, like sex and hunger, pregnancy and birth are natural, normal, and physiological life events, except birth is less frequent. And we have not associated the activity of giving birth with our ability as women and our birth coaches to become highly skilled. There was a beginning part in the 60s to the 70s where Lamaze and Bradley were saying that skills benefited, but they didn't say skills benefited 100% of pregnant women who were going to give birth in order to reduce our own suffering so that we felt more in control. They targeted low-risk women and then assumed that low-risk women using skills didn't need assessments, monitoring, and procedures, with the assumption that low-risk women would have a low-risk birth with a positive outcome, and that the woman wouldn't suffer from the natural occurring pain of labor contractions, which is not an accurate assumption. Any woman that is perceived as low risk, she can suffer in childbirth, she can just not cope well with the pain, or problem can come up in birth to herself or with her baby that was undefined beforehand. It's true also that women with multiple high risks, they can easily get a baby out of their body and find the process to be easy. So there really has never been this correlation. And the medical profession knows this. So what they do is to assess everybody, and they try to pick out the issues that you might have and then monitor your issues, and if necessary, do procedures appropriate to you. But that's not how the rising natural birth movement saw it. They saw all these assessments and monitoring procedures as interventions, with the implication that the word intervention didn't mean that there was a problem and a doctor would intervene and be able to resolve the problem without a tragedy. The word intervention in childbirth was not used that way. It was used to say they are unnecessary and they're imposed on women. Why did that phrase get used? And it had to do with the conversation around the world, natural birth. So there was this huge split that occurred in my lifetime. And because I became involved in the conversation at that time, I can explain to you how it occurred. So when I gave birth in 1970, when 95% of us in the United States labored and had a vaginal birth, alongside all the assessments, monitoring, procedures that were being done, it was considered to be normal, natural, and physiological to labor and have a vaginal birth, whether you had risks or not, whether you suffered in childbirth or coped well, whether you labored for hours or days, whether you had a good outcome or a tragedy. all of those things were considered to be natural, normal, and pretty much physiological, which meant that the interpretation of natural birth followed the global understanding of it across all cultures, which is that pregnancy and childbirth are a unique period of life. They are natural and normal, and they have risks associated to them that are not associated to another time of life, and that people should pay attention to the potential of those risks, because nobody wants a risk to become a problem and that problem to become a tragedy. Thankfully, there are many more risks, there are much fewer problems, and infinitely fewer tragedies. But how do we know if we have a risk? Well, we have to be able to define what is normal or what is not risky, right? And so it becomes a challenge, because if we have a risk and the risk doesn't become a problem, then there isn't a tragedy associated to it. Or if the risk does become a problem but doesn't lead to a tragedy, then it doesn't matter if it's become a problem, really. So we have this understanding that pregnancy and childbirth are normal, natural, physiological life events, and that those words embrace and incorporate all aspects of pregnancy and childbirth around the world, in every culture, for all women, which means it is normal and natural and physiological for some women to be living where there's a famine. They don't like that. It's normal and natural, and it's not physiological to be living where there's war. Nobody wants to be pregnant and to give birth during that, or a natural disaster, or when there's a substance abuse or physical abuse in the home, or you're living in poverty, or you're having children that you don't want, and you're sick. And so we need to understand that the word normal, natural, even physiological has a much broader meaning than how it has become used by the natural birth movement. So given my explanation, you can see why I feel cranky about that message. Because when we imply to one another as women that pregnancy and childbirth are normal, natural, and physiological, with the meaning that they are easy and safe and a nothing burger with a good outcome, and that we're going to just do fine, then as women, we're not telling the truth to one another. And when we don't tell the truth to one another, and a childbirth conversation is based on a lack of honesty or truth, then we can understand why so many women are so confused by the process. So since the late 70s and 80s, it has been drummed into us by the natural birth movement and famous authors that basically, if you just let women alone to discover birth, and midwives sat in the corner and knitted, and everybody went to a midwife, and everybody had a home birth, particularly in water, that we'd have all these women having orgasmic births, and wouldn't that be lovely? And it would be safe, and everything would be hunky-dory. And so the message that we're given, the ideal birth, the image of birthing women, is an image that leads to the shame, blame, guilt, disappointment, anger, frustration, and birth trauma that we see today. So it's important for you to understand in your pregnancy that you are going to have assessments, monitoring, and perhaps some procedures, either by the staff, either a labor delivery nurse or a midwife staff, by an obstetrician or a general practitioner, or by your home birth midwife. They're obligated by their profession to do certain things. Those are called standards of care or guidelines to practice. They're required to do those things Because if they don't do those things, then they can be held responsible for poor outcomes. So today we're going to talk about 6 of these interventions, and there are 30 of them. let me put them up for you so you can see them in all their glory. And there they are. So that's a lot. Wasn't going to talk about all of those today. So we're going to just talk about them, and there's no particular order. Women have never made a hierarchy of these orders and said these are the ones that are most important. But you hear it. You can go on to Facebook and all the groups, and you hear what women do and don't want, and that's the same thing that really they've been saying since the early 1980s. Nothing's really changed. Once the choice-based trend became the predominant trend and moved away from the skills-based trend of the 1970s, then everybody was making a birth plan and telling their birth professionals what they want and don't want. But the choice-based trend that was advocated by the natural birth movement was not an equal opportunity choice. They weren't interested in more women choosing to have elective cesareans. They wanted women to choose to say no to what was now called interventions. So the first one is the vaginal exam. Vaginal exams aren't always pleasant to have done on you. Often you had to lie on your back. Often they were done in the middle of a contraction. And people were wondering, why are they being done? Actually, okay, so that's an assessment. Right? You're going in and feeling for how dilated you are. What's interesting as we developed these skills in the early 1970s was that for 99% of us, if we were told your baby's engaged or you're 50% effaced and 2 centimeters dilated, we had no idea what that meant. We didn't feel that in our body. So we had no idea what it meant. So if we had a vaginal exam or a VE done or internal done, and we were told, well, you're 5 centimeters, yeah, okay, what does that mean? Well, what we learned as we were developing these skills is it had to do with, one, sensations, because at 5 centimeters, your labor is usually more progressive and the contractions are closer together, longer, and more intense. But what we learned about vaginal exams was that they were helping the medical profession determine where we were. Where were we in this progression from being pregnant through to delivering the baby? We can sit there and say, they don't need to be done. And that's what people have been saying for a while. Nobody should have a vaginal exam done. But you know what happens is that you have women then start to push, is one example, and they push because their care providers haven't checked them or they haven't checked themselves. And they push for an extended period of time, and then it turns out that they're not fully dilated, and their cervix is now swollen. So you need to understand that the reason that vaginal exams were done was, one is to find out where women were, and the other is, and to some degree, to determine the position of the baby. Now, what did we learn as birthing better families? One is stick your finger up your crotch and find out where you are. You can't feel as far back as if somebody else is doing it to you and you're lying down on your back, because they're really reaching for the cervix, because the cervix is in the middle of a clock face, and that clock face, if you feel from the beginning of the vagina, which is right under your pubic bone, that clock face extends all the way back to the middle part of your sacrum above your tailbone. That's a long distance. Most of us have no perception of where this hole in our pelvis is. We can hold up a bony pelvis and look in it and just go, here's my face in it. And we go, well, where is it in your body? And you go, yeah, I'm not so certain where it is. Because the inlet is above the pubic bone and you can't reach further back to your sacrum. The mid-pelvis is inside you, and we, as women, with our bodies, pregnant or not, we can't feel much of the mid-pelvis because we're oriented towards the front of our body. But our partner can. If we lie down on our back, they can get in there and feel the inside of the bony pelvis. And it's important, actually, to know that, because that inside of the bony pelvis is the narrowest part of your pelvis that your baby has to come through. And it's not always symmetrical. So it's important to know about those things. And the outlet is between your sit bone and from your pubic bone to your tailbone, and you're sitting on that now. So we can check ourselves, because when the cervix is fully dilated, it's behind the pubic bone. And we can feel that. We can slide our finger into our vagina and keep our middle finger on the tissue and slide it in. And you'll notice that the pubic bone hooks, and then you can slide it up and feel the top of the vagina. And as far back as you can feel, which isn't very much, maybe an inch, if you're not dilated that far back, then you still have anywhere between 3 and 4 centimeters to get to the inside of that pubic arch. And that's usually when women are trying to say, where am I? Because the contractions are changing more frequently and are more intense. So is a vaginal exam important? Well, if you do it on yourself, you know where you are. If you've learned to feel where your baby is in your belly, and then connect what you're feeling in your crotch to where your baby is, because your baby's head, the size of a grapefruit, has to come down through that hole. So when a baby is engaged or at zero station, you can feel a curve to that baby's head. Then you'll know more. That's an assessment. And you can monitor that every few days in the last week of pregnancy. So the vaginal exam comes in handy. You can ask a doctor or midwife to do them while you're standing or sitting on the toilet. They may do that now. When I gave birth last, I checked myself, and the doctor said, I need to check what you found out. And I'd go, okay, not a problem. We worked together, because that doctor needed to have information to follow the guidelines of their practice. And the doctor was fascinated that I went in and checked myself. So you can also ask them to wait between contractions, although they like to feel what the cervix is doing during a contraction, whether it's being retracted back into the inside of the bony pelvis or not. And it comes in handy if your labor contractions seem like they've been going on forever. Is there change? That's what you're looking for. Where am I is actually a statement of what's changed inside me. And so when you feel inside, when you do self-checking, or you have your partner self-check, then they or you can feel change. And that helps connect this part of your body to that part of your body, and helps you respond rather than feel that this is happening to you. You are working through this activity. So the second intervention, or this is a procedure, is the artificial rupture of membranes. Now, why do doctors artificially rupture membranes? There's actually a belief that if a baby's head is applied to the cervix, funny words, isn't it? Engaged, applied, right? Zero station, effaced, what's that mean? That if the head is applied to the cervix, that causes almost an irritation to the cervix and will help it dilate. So there's a belief that if you get rid of the amniotic fluid, that the baby will then be more applied to the cervix. Artificially rupturing membranes also can help speed the labor along. It's an irritant to the body. A lot of people don't fully understand that if a baby is surrounded by fluid and you're having a contraction, the contraction of the uterine muscles to the baby is softened by the fact that the fluid is around that baby. And when that fluid is gone, then the contractivity is more around the baby. So why did they start rupturing membranes? It really was to get labor going to a large extent. If the labor looked like it was stalling, they'd rupture the membranes with the hope that that loss of fluid, that closeness of the uterine muscles to the baby, and that irritation of the the baby on the cervix would get the labor going. Does it? Sometimes it works well, sometimes it doesn't work well. Can you stop them from rupturing your membranes? That's one of the things you want to talk about beforehand. Many women, when they actually are in the throes of labor, don't mind it at all, although some of them, after the membranes have been ruptured and the labor picks up and gets more intense, that's harder for them to cope. And why is it harder for them to cope? Because there's no societal message that when you're pregnant, it's normal and natural to self-learn birth and birth coaching skills and use them. So the generation from the 80s to today, nobody's skilled. Nobody is reducing the suffering. So if a woman is stalled in labor and she accepts the membranes being ruptured and labor picks up and it gets more intense and she doesn't have the skills, she doesn't like what has just happened, even though the labor is now picked up and it's moving along. So this is why our trust has constantly been saying to people for 50 years, we need a childbirth conversation and a trend in childbirth that recognizes that this is an activity we're doing and we all need to be skilled to do it. In fact, when I explain this to people now for 50 years, we know that birth is it's a physiological human process. So is being horny and so is being hungry, right? And we know that if we gave birth as frequently as we have sex or as frequently as we're hungry, there would be millions of authors out there sharing skills with us. But because it's so infrequent and because the natural birth movement has been so fixated on this physiological aspect that labor is a natural, normal part of life, the implication that they gave was that cows and cats aren't taught to birth and women don't need to be taught to birth, that it's demeaning to us as women and that we should really just be left alone to be instinctive about birth. And this is why I'm cranky with the natural birth movement and why Birthing Better families that develop these skills, we're cranky with that message. Because many of us, millions of us have been left alone in birth and we suffered. We wanted people to help us. We wanted to have skills. And so when the skills-based trend occurred in the 60s and the 70s, we all became skilled and we significantly reduced the suffering. And that's what hospital staff and obstetricians saw. They saw us cope better. And our generation was not left with the trauma that the generations has since the choice-based trend has been put in place, because women are being told, you know what kind of birth you want, so write a birth plan and they should give you the birth you want. But that's where the misinformation comes from. Babies don't come to plan. You never know what your birth's going to be like. You can't plan your birth. I've spoken globally to tens and thousands of women in 50 years. I could probably count on this one hand how many women said, yeah, my birth was exactly like I thought it would be. I mean, really, most of us, it's like wasn't anything like I thought it was going to be, which tells us why we need to be skilled, because it is our Mount Everest, it is our Olympic event, and we should elevate it to an activity that we can skillfully work through. And that doesn't mean that we necessarily have a great birth or a birth we like or one we weren't afraid of or wasn't fiddled with. It means we're doing the activity of birthing our baby, and we get pregnant and have a baby, not a type of birth, right? So if you have your membranes ruptured, whether you want them ruptured or not, and it changes your labor, you want to have the skills to cope with that change. Doesn't that make sense? Well, to us, it's always made sense, right? But what made sense before that is to try to have you skilled so that doesn't need to be happening, because you've prepared your body for birth and you're coping well and you've learned how to open up your body to let this baby open you further, then come down through and out your body. And this is why when the skills-based method started in the 60s and the 70s, and those skills were the beginning skills, if they had been encouraged to evolve as birthing better was this massive evolution of these skills, and then had been coupled with choices, then if women were choosing to have less medical care, less assessments, monitoring, procedures, then they would have done the work to try to reduce or prevent any risks they had from becoming problems, and any problems from becoming tragedies, because that's really what birth is all about. How do you explain this? By nature, if you just let women alone, yes, some women die in childbirth, it's infrequent. Some babies die in birth, a little bit more frequent than mothers do. That's true. But if you get in a car, you're more likely to die. If you have a heart problem, if you have cancer, if you have anything, you're more likely to die. However, we used to have lots of kids because there wasn't any contraception or abortion that was safe and legal for women. And there was no immunization or antibiotics until really very recently. My grandmother died of pneumonia at 39, my grandmother, before there was penicillin. So you need to understand, when you go to any cemetery around the world, before there were antibiotics or immunizations, which are procedures to try to prevent childhood illnesses, we lost between 20 and 30% of our children before the age of 5. And we had more children. We didn't often lose them at birth. We lost them afterwards. And this is why the focus on childbirth has added to the complexity about this, because we have fewer children, and so we want to reduce the risks in our pregnancy and our birth for this one or the second child that we might have. So this third intervention that I mentioned on this is doctors. When the natural birth movement started to form in the 80s, it really was, and still is by far, an anti-medical movement. And it has sucked all of us into that. There is a belief now that a natural birth is an ideal birth, and that a medical birth is a less ideal birth. And this is demeaning to us as families. We get pregnant to have a baby. Our baby's important to us. The birth we do with that baby is an activity we do. If we do it with skills, no matter what the birth's like, we can drive to the hospital, be prepped, lie on the table and have a cesarean. We may like it or not like it. But if we use breathing and relaxation skills, if nothing else, and we consciously are doing this through that time it takes for our baby to move from inside our body to outside our body, we feel more empowered. We're more engaged and we're more active. And if we're doing that with our baby's father or somebody who loves this child and is going to be in this child's life, then we enrich our families. That makes common sense. So you'd think this concept would have taken off 50 years ago, that when you're pregnant, it's just normal and natural to learn birth and birth coaching skills and use them in the activity of birthing your baby. And that concept has been totally denounced by the natural birth movement, who believe cows and cats aren't taught to birth, women don't need to be taught. It's demeaning to women to believe that we need to be taught how to birth, because it's instinctual, isn't it? So that belief is then that doctors are what has interfered with us from having these natural and normal physiological births, with the meaning of those words that it is easy, that it is safe, that it is manageable with a good outcome. So you understand how this has become complex. Why do we, modern people, go to a doctor or a midwife? Because we would like them to do monitoring and assessments and procedures when necessary. We can't learn all things. We drive cars. Why do we go to mechanics? Because a lot of us don't know how to repair our cars, right? So we go to professionals because they have skills that we don't necessarily have. And we rely on them to use the skills in pregnancy and childbirth to safeguard the health and well-being of ourselves and our babies. This is why we go to either midwives or doctors. This is why we use them. So a doctor is could be your grandmother, your grandfather, your mother, your father, your aunt, your uncle, your cousin, your brother, your son, or your daughter. These are human beings who have chosen to be in a helping field. They are there to safeguard the health and well-being of you and your baby. So when we hear that doctors are an intervention, meaning that they're unnecessary and imposed on us, and that they are preventing us from having this natural birth, then you can understand why, for me, being involved in this conversation for 50 years and a director of a trust where I worked with hundreds and hundreds of fathers and mothers who developed these birthing better skills, every single family was choosing whether they were going to have a midwife or a doctor or do it alone. And why did most people choose doctors? Well, one is in the United States, there were no midwives, right? And people were still doing births, but they chose doctors because doctors were the most highly skilled of that professional hierarchy. And so then it became a negotiation with the doctor about what you wanted with a birth plan. Everybody became very frustrated with birth plans right away because women had lists and lists and lists and lists, and nobody knew what a woman would be pissed off at afterwards. And I can tell you from having been involved in this, I didn't know. Husbands didn't know. So let's say you just had a woman who said, no, I didn't want to have a vaginal exam and I didn't want to have my membranes artificially ruptured. Let's just say she didn't want those two things, right? And so let's say she got into labor and the labor doesn't progress and she's sitting there going, I don't know where I am. Somebody tell me where I am. She's going to then want a vaginal exam. And if her labor's gone on and on and on and on, she might want to get it going. So she may then actually want or choose or accept her membranes being ruptured. Then 6 months later, 18 months later, she can be pissed off at that, right? And nobody can understand what the hell happened, right? Nobody can understand. So that's why skills were so important, because whether you made those choices or not, if you kept using your skills, if you kept doing the work, kept working through this activity, you accepted those choices or those impositions on you, and you just put your blinkers on and did the work. And that's where the empowerment came from, which was doing the work. So not following the birth plan. Well, gee, just told you that one. So too many women have lots of ideas about the birth plan because that's the childbirth trend. You know what you want for your birth. So tell them. And we even hear today that the role of the birth provider is to do everything they can to give the women the birth they want and to involve her in informed consent and decision making. I can remember just about going under anesthetic for major surgery and the anesthesiologist coming up to me and saying to me, there are certain risks involved in this and blah, 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 blah. And I thought to myself, now, am I going to say no at this moment? I mean, probably not. So it's very difficult. Informed consent is very, very challenging because there is no blanket risks. The risks are specific to you and specific to that moment. It's very, very difficult to determine if you have a risk, whether it's going to become a problem and whether that problem is going to become a tragedy. It's very hard to involve women in informed consent. Very, very challenging too. So can you follow a birth plan? What we've been saying for 50 years is if you are skilled and you want a particular type of birth, you're more likely to achieve that type of birth because you've done the work to prepare your body and you're doing the work to work through the birth that you want. And more than that if the birth doesn't unfold the way you want, you still commit to using your skills to work through the activity of birthing your baby. So when we hear that an intervention is not following a woman's birth plan, that actually is like, pull your hair out. I mean, really, do you know how hard that is to actually say that to any birth professional or to say that to any father who has been at a birth and has recovered from a birth with a woman 6 months or 18 months later bitching at him because she didn't want any pain relief And after 20 hours of labor and not having skills and being absolutely bloody exhausted, she begged for an epidural, felt relief from an epidural, whatever then happened, and then 6 or 18 months later felt that he should have stood up to her not wanting an epidural. And do you know how common all of this is? It's really common. It is really common. So when we see this on a list, now you may ask, where did I get this list from? Because this is going to be a 6-part series within a series. I teach midwives, right, to strengthen their partnership. Because midwives do not, by and large, believe that their clients should be skilled. They believe they should be skilled. And they should be skilled for what they consider to be a normal, natural, physiological life event. So why should they be skilled? Why just not let it happen? And if they're skilled for the just in case or to be able to do assessments, monitor procedures, why don't they advocate for us as women to be skilled so we can prepare our body and cope with this activity we're doing with our baby? I've never figured out why this concept is so rejected by the natural birth movement and the midwifery movement, but it's been resoundingly rejected for 50 years. And today it's still rejected when I reach out to people. So what we need to understand is that if a woman has a birth plan in which she doesn't want assessments, monitoring, procedures, then her birth professionals should be asking, what are you going to do to make that birth happen the way you want it to happen? Because she's the only one. We're the only one doing the birth. There's nobody else. That midwife or doctor, they're not doing the birth for us. Nobody can do the birth for us. Even if we're lying on a table having surgery, we are doing the activity of birthing our baby. And that's why the concept should just grow and grow and grow. It just should be natural and normal to learn skills and use the skills where you do the activity of birthing your baby. Sounds simple. It's rejected based on the fact that interventions are assumed to be imposed on you and unnecessary. And if they don't occur and you leave women alone, then they will just birth fine. Do you understand why there is so much shame, blame, guilt, disappointment, anger, frustration, and birth trauma for the past 50, 40 years, 30, 40 years? We are, as women, we are setting ourselves up. And this is what's such a shock. And this is why it needs to change. I disappeared for many, many, many years. And I came out when COVID came out. Because I just said, no, too old, can't shut up any longer. So I'm doing these series. And just pass them on. So the next one is women being afraid. The second video in this series on our YouTube channel is about fear in pregnancy. There was a very famous obstetrician, Grantley Dick Reed. He taught classes in New Zealand. And that's where our trust is, and that's where I lived for 25 years. And that's a midwifery model of care that has a very, very weak partnership. Women choose, and midwives are expected to provide them the birth that they want. And the cesarean rate has doubled, more than doubled. It's almost 30% with continuity of care midwifery. So we wanted to strengthen the partnership. And that's what we were asking midwives. What do you want as a profession for women? Well, we want more natural births, right? Which was, we want an easy birth, a good outcome with women with COPE who have home births, who have a natural birth and are left alone to discover birth. What's stopping women from achieving this? Interventions. Okay, let's make a list. And they came up with these 30 interventions, in which I'm going to do a series about. So one of them is that if women are afraid of birth, this impedes their birth. And this is what I tried to explain is no. Right? There's a simple answer to that. No, that it doesn't. Okay? Many, 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 many women are afraid. In fact, humans are hardwired to be afraid in pregnancy and childbirth for a good reason. It's a gift. Because when we are afraid, we become more observant. We become more aware. And the reason we become more aware and observant is because if everything's going fine, we're aware of that. And when something starts to go off kilter, we become aware of that. And if it goes way off kilter, then we seek to do something or seek help. So the gift of fear, any time in your life, if you feel fear, recognize it as a gift and become observant around this. And a wonderful book on this is called The Gift of Fear by a guy named Gavin de Becker. Very good. Not about childbirth at all. It's very, very, very good. Another reason that we're hardwired to be afraid in pregnancy and birth is if we develop this gift of observation, it is what we use once our baby is born, because babies can't talk to us. We are seeing and hearing the sounds they make and the movements they make. If we have been told, don't be afraid in pregnancy, everything's fine, and we suppress that fear, we're anxious all the time. We just have fear of telling people we're anxious all the time. So when that newborn comes, particularly for first-time parents, every time that baby squeaks or moves, you hear the parents go, what's the matter? What's the matter? When if they had grown this gift of fear to observation, they would have then said, oh, I'm going to observe this. If I think that my baby or I are at risk within 5 minutes or 12 hours, I'm going to go get help or do something. But if I don't think it's that immediate, I'm going to still observe. Because if it gets worse, I'm going to seek help. But if it resolves itself, I will have learned something. So when women being afraid is put on a list of interventions by midwives, women who are talking to other women, we have a problem. A major problem. And it's been a major problem since Grantley Dick Reed to tell women that fear will stop them from laboring and that fear will stop oxytocin, this love hormone. Nonsense. Nonsense. Okay? Fear doesn't stop any of that. If a woman's baby fits easily through her body, honestly, she could be standing on her head, that baby's going to come out. If she doesn't fear anything and that baby doesn't fit easily through her body, it's going to take a while for that baby to mold into her body and her body to be pushed open by that object inside. That's why birthing better mothers and fathers develop skills to prepare their body. That's the evolution of the skills of Lamaze and Bradley and Grantley Dick Reed. This was so important. So if you're pregnant now or know somebody who's pregnant now and they are afraid, tell them it's okay and try to go to our YouTube channel, Birthing Better 1, with a capital B, Birthing Better, capital B 1, and go to this playlist called You in Childbirth and listen to the second one about the gift of fear. Because we want women to grow, and men, to grow this gift, so that they can be observant and they can pay attention. Okay, so the last one I'm going to talk about is induction of labor. Now, as I said, when I gave birth in 1970, 95% of us labored because cesareans were so major and risks were considered to be normal, natural, physiological, and accepted. Okay, so, you know, rupture membranes is a way of induction of labor, but they can give you something else. They give it with an IV. They didn't used to give it as an IV. They should give it to a shot in your butt or your leg. So why do they do that? Well, they do that because, and this is sort of kind of hard to explain. Take medicine out of this, okay? Just take all medicine out of this. So just remember what you don't know, okay? Humans have existed for a long period of time. When women get pregnant, how long does it take for most women to actually know they're pregnant? Well, without the modern pregnancy test that did not exist when I was pregnant in 1970, not for months, okay? It takes 12 weeks, okay? 3 months for the uterus to be felt above the pubic bone, okay? 3 months. Women may sense it. Some don't have their menstrual periods. Some still have bleeding. Right? It can take months. You don't feel your baby move until 18 to 22 weeks, which is another series of months, right? So nobody knew when women were due. Nobody did. Even when I gave birth in 1970, they used to say, when did you get your last menstrual period? And then they calculate what, a week back and a day forward or something like that. Nobody knew when you were due. Nobody knew, which meant they really didn't care. So we didn't sit there and go, as people are going today, 40 plus 2 days. We didn't even think about it, right? So we got it, just amazing. Did we have inductions of labor? For my first birth, I did. I had my membranes ruptured, and then I was given a shot. Were those the standards of care in the hospital at that time? Those were the decisions that were made by the doctor in a trend in which it was follow the doctor's orders. I didn't have choices. Okay. When I gave birth last in 1982, I gave birth in another hospital, I didn't know, with an 8-week premature baby. And they then wanted to try to stop that labor, right, by putting in an IV. So an induction of labor is one of the things that women now believe stops them from having a natural birth. Why? If you have your membranes ruptured, it takes, 30 seconds? Then you can get on with it, right? If you have a Pitocin, to keep your labor going, it will be an IV. You've got to get on with it. You still have to do this activity. And if you have ruptured membranes and your labor just does whatever it does, or you have Pitocin and then that's sort of an artificial stimulation of your uterus, you still have to get on with it, whether it changes the contractions or not. You just got to get on with it. So can you see where this concept of it's natural and normal in pregnancy to learn skills and use them just fits right into that? You can't necessarily stop the medical profession from assessing or monitoring you or doing procedures. They now know, which they didn't even know in 1982, that because they started to do ultrasounds. They didn't do ultrasounds in 1970. They did them rarely in 1982. They didn't start doing the due date calculations for a very long time. Then they started to notice that when women had babies that were theoretically late, past 42 weeks, that some babies had more difficulty. Okay, these are risks. And there are a lot of risks, but they're defined risks. My 8-week premature baby was a risk, right? Risks don't necessarily mean there are problems, nor do they necessarily mean there are tragedies. But we don't always know at the level of a risk. We don't always know at the level of a problem. So we're trying to reduce or prevent these risks from becoming problems, prevent these problems from becoming tragedies. And the medical profession and the midwifery profession does it through assessment, monitoring, and procedures. If you have an induction of labor that is on your birth plan that you don't want done, and it is imposed on you, or you agree to it, this is what we want you to know. Get on with it. And why is this important? Do you have kids? Are there days when you want to just murder them? I mean, honestly, they can be horrible. How about your partner? How about your work? How about the weather? How about COVID? How about the angers right now? You got to live your life. It's called get on with it. You've got to live your life. So people who are skilled in times of challenges cope better. They manage better. They deal with things better. They handle things better. They stay on top of things, and they feel more in control. Pregnancy and childbirth are normal life events. They can be easy, piece of cake. They can be really challenging. They can have great outcomes. They can have tragedies. They can make us feel wonderful. They can make us feel very challenged for years to come. If we had a skills-based approach to all births, we would have more people feeling empowered as they work through the activity of birthing their baby, all around the assessments, monitoring, and procedures. They would make decisions at that moment that suited them, and decisions are fickle things. You can make a decision not to get induced and end up with a problem. You can get a decision and be induced and end up with a problem. You can't replay it. You're doing the best you can. And you birth better when you use skills. And you adapt, adjust, and modify those skills at every moment of the time. Not unlike what we do when we drive a car, except driving a car isn't natural, normal, and physiological. But we expect in society that everybody learn the same skills, and we expect that they adapt all these skills very subtly at every moment that we're driving. Because if we don't, we're more at risk, and we're more at risk of harming someone else. So I've run out of words today, honestly. What I'm going to do is go on to the number 2 tomorrow with the next 6 interventions. Thank you very much for listening to this. Hopefully in the next few weeks, we're going to start to do webinars. We're going to do some free ones. I'll start teaching online again because honestly, I'm just finding myself really cranky. And I don't want to be cranky because I want to inspire you as pregnant women and men to become skilled. And I want to inspire the birth workers to inspire their clients to self-learn skills. And it's just simple. Just say to them, you know, we respect your choices. It's an activity you're going to have to do. Here's a handout of all the skills-based methods. Please choose one or more of them. And then, you know, we'll mark on your notes what your choices are and what skills you've learned. And then as your birth unfolds, if your choices unfold the way you want, oh, yippee. If they change, we're going to involve you in decision making. And if you look like you're coping well, we're going to smack you on the back and say, well done for coping well and using skills. And if you look overwhelmed and stressed, we can look back on your notes and say, oh, you learned breathing and relaxation. Women can say, I said I did, but I didn't. That happens. But they can say, well, I didn't think I should keep using those skills because something has changed. I've had more interventions than I've wanted. As a birth professional, you can say it's still your baby's birth. Just work through your baby's birth. Right? It's your baby's birth. Think of how you feel, continuity of self. If you're a skilled human being, then you get pregnant and suddenly feel very unskilled and sort of moved along by all these changes, and you don't have any skills approaching birth, and you don't have any skills in birth, and you get spit out being a parent at the other end. That's going to feel a lot different than if you're a skilled person, you get pregnant, and at some point you begin to develop skills to prepare your body for birth from 24 weeks onward, learn skills how to work through the activity of birthing your baby, use your skills to work through the activity of birthing your baby. You are more likely to find yourself in a more favorable psychological position once your baby's born. Makes sense. So anyway, thank you all for listening to me, and I don't know. Have a great day and see you again. Bye-bye.